There we go. So we like to start off our Food Policy Council meetings and our other events and activities with a land acknowledgement. We think it's important to take a moment at the beginning of our meetings to just be grounded in the place that we are at. A lot of the work that we do is place-based, right? We work on projects in Hampshire County in particular and the region, and we just feel it's really important to acknowledge the history of the land that we're on. And so we start our meetings sort of with this acknowledgement. So I'll read it today, and I invite you to just take a deep breath and sort of feel grounded in the place where you are, wherever you are. And I'll read the acknowledgement. So this is a land acknowledgement for the contemporary Franklin, Hampshire, and Hampden counties region. We acknowledge that we're on colonized ground, appropriated through a series of actions intended to destroy, seize, or diminish Indigenous people, culture, and resources. We deeply consider historical realities, the impacts of settler colonialism, and how profit and harm still derive from these events. In response, we affirm Native American identities in this community today and a vibrant cultural legacy. Every time we gather here, we must acknowledge and respect that fact. We respectfully support the healing and restoration that is underway, and we yearn for a genuine peace in our time and for generations to come. Thank you. So for folks that may be coming to the Learning Circle for the first time, we like to just give a little overview of who we are and maybe why you're here. So this event is hosted by the Hampshire County Food Policy Council. We're an emerging council, still sort of in development. We've got a group of 9 people that have been meeting weekly for many months now, more than a year. The group is currently called the Startup Circle for the Food Policy Council, and it's made up of 5 community members and 3 staff from the Collaborative for Educational Services and Healthy Hampshire, and then our sociocracy coach and trainer, Andy Grant, who's also here. And we also have organizational partners in this project, Cooley Dickinson Healthcare, us, the Collaborative for Educational Services and Healthy Hampshire, where I work. Caitlin Marquis also usually runs these meetings. She's on vacation right now. You might know her, and Rosanna Salazar, I think, is also here, one of our Healthy Hampshire team members. Then we've got the Startup Circle that I mentioned, and then our other organizational partners are the Hilltown Community Health Center and Hilltown Community Development. And then our funder is the Massachusetts Health Policy Commission. So we like to give an update about sort of what's going on with the Food Policy Council right now. One of the exciting things that we have to share that we mentioned last time is that we've recently developed our vision and our mission for the Food Policy Council. So we have here our vision. I'll read it. It's really exciting. We have consented to this, and we feel really happy with how beautiful it came out. We envision a resilient, community-owned regional food system where all people are empowered to live more joyful and gratifying lives through access to affordable, healthy, locally grown food of their choice. And our mission, we cultivate shared governance and a countywide network that builds the power of community voice to make food policies more equitable, honor diverse cultures, and help local food economies to flourish. So I wonder if anyone else from the Startup Circle who's here would like to unmute and share some of the other work that the Food Policy Council Startup Circle has been doing in the past month or so since we had our last meeting. I know we have, I think Roz is here, and Andy and Yohani. Anybody feel compelled to give some updates? Yeah, Andy, go ahead.
While you have this vision and mission statement up, that word flourish. First of all, these statements were developed by a helping circle that worked over a period of weeks to craft from community feedback a statement. And then this was brought to the startup circle. That word flourish, we tried out a few different ways of saying that. And it turns out that in English and Spanish, flourish had the most meaning and the most resonance for the group. That's an example of the kind of detail of what we were doing. We've worked together. I've been with this project almost 2 years, and we've chosen a format for group decision-making, sociocracy, and have been training quite a lot in that area. We now have a vision and mission. The next thing we're doing is grappling with, okay, how do we build a food policy council on this foundation? And that's the question of the moment. Check.
Yes, absolutely. If Roz or Johanni, if either of you want to speak, feel free to unmute. I'd also like to share, one of the recent projects that the Startup Circle has been working on is a grant making process. So we have some funds for community-based organizations who are really focused on shifting power from professionals and sort of the usual kind of people who hold power in our communities toward community members and residents. And so we released an RFP for a small grant, 3 grants of about $10,000. And the RFP was also developed by a helping circle, which is sort of like a working group of residents, community members, and professionals co-developed the request for proposals. We finally have gotten the applications in, and now we're launching into a participatory grant review process. So together, we're all reading the proposals, all the Startup Circle members, and filling out a scoring rubric, and we'll be coming together in a meeting this month to actually select together who will be awarded the funds. So this is a bit of a pilot for us. First time we're doing this, but so far it's been a really, really interesting process, and it's brought up lots of questions about where power sits in, especially in grant making processes. And we're excited to be able to select our awardees and announce them later on this month. So that's been an exciting piece we've been working on lately. I'll also say that, the Food Policy Council has really centered, inclusion and wanting this council to be a space for community members especially. And so we're really working hard toward developing a structure, and we're almost there, where we'll be inviting lots more people into this work, and the opportunity to sit on working circles and to be participating in project development and ideas, and also sort of building our network of people who are just, interested and want to be affiliated with the work that we're doing. So there's going to be a lot more opportunities to be engaged as we continue on. We did our updates. I just want to share this. Many of you probably have filled out this survey because that's how you probably got on the list, where you got this registration link. But if you haven't, then please fill it out. And if you know anyone who's interested in the work that we're doing or might want to be involved with the Food Policy Council, send them this link. And that's how you sort of get onto our mailing list right now. And I'll just share one last detail. Our next learning circle will be July 27th. Same time, 1 to 3. So I just encourage everybody to save the date. We don't have our topic selected yet. If you have ideas, please let us know. You can always put something in the chat or send an email. We're always open to developing these learning circles around what folks in our network are looking for. food is medicine topic was actually a suggestion of someone in our network. So we're really happy to be able to make these circles, the topics, what you're looking for. I think this might be my last slide. Yeah, so let me just double check that I haven't missed anything before we get started. I think we're okay. So I'm really excited to introduce our presenters. So again, the topic today is Food is Medicine, in particular Food is Medicine Massachusetts, this coalition that we're going to learn a lot more about today. So we have Hannah Sobel, I hope I'm pronouncing that right, yeah, who is the Food and Health Policy Program Manager at Community Servings and is also co-chair of the community-based organization task force of, I don't know if you pronounce it FEMA or FEMA, but we'll learn. Well, I think we'll also, feel free, Hannah, to give us more info about what your organization does and anything else you want to share. And we also have Jessica O'Neill, Executive Director of Just Roots, and also co-chair of the community-based organization task force of FEMA. So I think I'll hand it over to you two. I think I'll stop sharing so that you can share, and we'll let you pick it up.
Great. Thank you, Kristen. It's wonderful to be here and to see what will become a food policy council in Hampshire County, and really excited that you've all have expressed interest in food as medicine, because that is the world that we operate in. So we'll get started. So we already had an introduction, so that's great. And we do pronounce it FEMA, so you had that right, Kristen.
Can I interrupt you just 1 second, Hannah? I just wanted to remind anybody that came in before I made this announcement at the beginning, we are using the language channel function so that we have English and Spanish available. So if you go down to the bottom of the screen, you'll see a globe that says interpretation. And if you select that icon, the option to choose English or Spanish will come up, and you should choose the language that is your primary language. In case that means that if somebody speaks Spanish in the meeting, you'll be able to hear the interpretation in English, or if you speak Spanish, then you'll hear the presentation in Spanish. Okay, there you go. Go ahead, Hannah. Thank you.
Okay, great. So also, as Kristen mentioned, I work for Community Servings. We're a medically tailored meals provider based out of Boston, but also serve the whole state. I'll be joined a little bit later in the presentation from Jessica, who I hope that some of you should be more familiar with from Just Roots, operating out of Greenfield and serving broader Franklin, Hampshire, and Hampden counties too. And she'll introduce a little bit more about Just Roots later on. So today, just to give all of you a sense of what's coming up, we're hoping to just do a very brief introduction about our coalition, of what we do. And then I'm going to dive into it about how we define the world of food as medicine. So there are different intervention types, as I'll explain later, and I'll introduce how we define those and what those types of interventions entail. After that, we'll hear from Jessica to give sort of a case study about Just Roots and in the world of food as medicine. And she'll also outline sort of the data and why we need this food as medicine movement, and what the research is showing about how important these types of interventions are. After that, we'll stop talking at you, and we will have an activity for you all. So hopefully the technology will work, and the activity will, we'll hear from you about what food as medicine means to you, and then hope to have some sort of discussion that comes out of that. After all of that, we'll go back to some presentation And I'll tell a little bit more about what our coalition does. So what are the projects that we work on, what are the issues that we care about, and how we work on all of those things. So I will dive into the introduction to FIMA. So FIMA is a statewide coalition. We are co-convened by Community Servings, which is where I work, and the Center for Health Law and Policy Innovation at Harvard Law School. And so our main mission is to enhance the role of nutrition in healthcare. As a statewide coalition, we have over 200 members representing over, I think it's 90 now organizations. And FIMA is pretty unique in that for the first time, we really organized food advocates and healthcare advocates together. And so as you see by the types of stakeholders in our coalition, we have insurers and doctors and other healthcare providers, as well as community-based food organizations. We also have a lot of researchers, advocacy groups, and some government agencies involved. So FIMA was originally created after 2 years ago, Community Servings and the Harvard Law School, we put together a report called the Food as Medicine State Plan for Massachusetts. Oh, that's the same thing. So this report, the Food as Medicine State Plan, the goals of that report were to assess the current need for and access to food as medicine interventions across the state. So it included a lot of mapping of where the services were, as well as looking at where the highest need was across the state and identifying which areas of the state were priority areas based on chronic disease prevalence, food insecurity, and barriers to transportation. So from all of that and looking at the evidence that we've seen for food as medicine interventions, as well as what the opportunities were for expanding food as medicine services across the state, the report concluded with a blueprint or a vision for what it would mean for the healthcare system to recognize the relationship between food and health. So after the state plan was created and launched, we had a lot of stakeholders who had been involved with the report itself, and those initial group of stakeholders formed our coalition, and we have grown since then. So with that brief background of what our coalition is, I'll just dive now into what we consider food as medicine interventions. And I will say that these definitions were created by our CBO task force over the course of about 1.5 years. And so it was a lot of the organizations that are providing these services who worked on these definitions, and other stakeholders such as other community groups that serve populations who need these interventions, or nutritionists, that sort of thing. So there are, this is the pyramid that we usually refer to explain what we mean by food as medicine. And the first 4 program types that are on here are what we consider food as medicine programs. So medically tailored meals, medically tailored food packages, nutritious food referrals, and community level healthy food programs. We don't necessarily consider SNAP or other emergency food programs to be part of the food as medicine world. However, we know that there's very obviously a connection between those programs and health, so we include them on the pyramid in recognition of the fact that that's sort of the baseline of where we want to start with. Is the baseline is food security and food access. Not necessarily through those programs specifically, but generally speaking. And we just so to understand how this pyramid works, is that towards the bottom are programs that are more on the prevention side of things for health, whereas the top of the pyramid is more of the treatment side of health. So medically tailored meals might be for, I'll explain them in more detail later, but it's for a treatment for chronic disease, whereas towards the bottom of the pyramid, it's more for prevention. So you'll also note that the size of the pyramid tier has to do with that. So prevention is going to generally be for a wider audience, whereas the programs at the top that are treatment, they're for a little bit more of a narrow group of people just based on who's eligible for the program. All right, so next I'll just dive into what these programs actually look like. So what is a medically tailored meal? So medically tailored meals are home delivered and ready to eat meals. And who is eligible for these meals are individuals with diagnosed medical conditions. They often have multiple conditions who are not able to shop or cook for themselves. And the key part of what makes a medically tailored meal is that they're customized to an individual's dietary needs. So, for example, someone who has both renal disease and is undergoing chemotherapy for cancer, they're going to have very, very specific dietary needs based on managing both renal disease as well as what chemotherapy will cause the body to go through. So the meals are customized to every individual's needs. And also the eligibility for these programs is also narrowed further because individuals are referred directly by their healthcare providers. So I listed community servings where I work as an example of a medically tailored meal provider. Oh, and I'll also note that I have a few identified programs for these types of programs throughout Hampshire County and beyond in a little bit. So next is a medically tailored food package. So these are pretty similar to medically tailored meals in that they're also for individuals who have a diagnosed medical condition. However, unlike a ready-to-eat meal, this is a bag of groceries, generally speaking. So it's for people whose conditions don't prevent them from being able to shop and cook for themselves. But similarly, there's also a referral from a healthcare provider, and the food itself is also tailored to an individual's condition. These are often available from food pantries. So one of the most well-known medically tailored food packages is out of Boston Medical Center that has a preventative food pantry. Next on the list of programs is a nutritious food referral. These are pretty commonly known as a produce prescription. We just called it something else because we know it is often more than just often a prescription, or it's also more often than not more than just produce. But the key part of this type of intervention is that it's a prescription or a coupon or some sort of healthcare referral for free or reduced price healthy food. Unlike the other two interventions, the food that's provided isn't tailored to a specific condition, so it's healthy generally speaking. But it's also, there's a healthcare connection, is that this referral is given to individuals from their healthcare provider, and it's that after they're identified as being at risk for chronic illness. So an example is an organization that's based out of Boston, but they have a program, About Fresh has a Fresh Connect program that's a debit card that allows that healthcare providers can work with About Fresh to load money onto the debit card and be able to sort of track their patients' progress in health after their patients redeem that debit card for fresh produce. And then lastly, a community level nutritious food program. It's a bit of a mouthful. I apologize for the names of these interventions. But a community level health, nutritious food program. This has sort of the widest eligibility. So anyone who lives in a community can access this program. There's not a specific healthcare referral that's needed. However, what distinguishes this type of program from a broader food access program is that the program itself is organized by both a community organization and a healthcare provider. And so again, there's these types of programs provide generally healthy food. It's not tailored to a specific condition, but there might be some program design where that community is identified as being at risk for a specific condition. So there are lots of different types of programs that fit into this category. So an example that I like to provide of what we would call a community level nutritious food program is a mobile food market that's located at a community health center. So, you know, there's the food access piece of a mobile food market, but then there's the co-location at a community health center that really puts that into the what we call the food as medicine category. So I just wanted to include this list of some of food as medicine in Hampshire County and beyond, just to give you a sense of what is happening in your communities. This is obviously very much a limited list. This comes from our initial data gathering when we did the state plan, and I'm sure that there are a lot of other programs that are out there that do similar work. So this is more of just an example list for you all, and when we share these slides, there are links to each of these programs if you are interested in learning more about what they do. So some medically tailored meal providers, community servings where I work, as I mentioned, we serve statewide. And then there are also some Meals on Wheels programs that do tailored diets. Not all Meals on Wheels programs do tailored diets, but the ones that do, we would consider a medically tailored meal provider. The East Hampton Community Center's food pantry does some medically tailored food packages. And then for nutritious food referrals, we have Just Roots. And then some community level healthy food programs. Again, this is probably a very limited list, but again, the East Hampton Community Center's food pantry, as well as Just Roots, and then the Caring Health Center in Springfield, in combination with connecting their patients with resources, they also provide disease-specific nutrition education. Any questions about all of that? I know we'll definitely get into discussion later, but if there are any targeted questions people want to know about, I'm happy to answer those now. Okay, great. All right, I'll pass it over to Jessica.
Okay, hi everybody. I'm really happy to be here, and Hannah's gonna be my controller, so I'll just say next slide when I'm ready, Hannah. And thanks very much for the translation support on the slides. It's really great to see that. So just by way of introduction, for those of you who don't know me, my name's Jessica O'Neill. I use she, her pronouns. I'm the executive director of Just Roots. Just Roots, for those who don't know, we're a nonprofit farm, and we're a nonprofit organization. We're working really hard to reinvent our food system so everybody has access to fresh and local food, and I'll say nutritious local food. We're located in Greenfield, so that's Franklin County. There on our farm, we have a community garden and we have production fields. Our food access programs reach predominantly low-income residents. And as Hannah said earlier in the presentation, our programs now span across Franklin, Hampshire, and Hampden counties. And that expansion is due to our efforts to become more of a food as medicine organization and program. And this year, we'll be expanding even further away from home into Plymouth County. And I'll share more about that with you towards the end of my slides today. So I'm planning on sharing with you a little bit more about Just Roots. What is our work? How do we approach food access? And how did we kind of migrate from a purely food access program to a food as medicine program? Next slide. Actually, I was supposed to be on this slide, so next slide again. On this slide, I've just put out a couple of definitions. These are meant to be grounding definitions. They're by no means exhaustive, but hopefully they help to just help us ground ourselves in some of what we're going to be talking about through the rest of the slides. And Just Roots, we've been working for a little over a decade, and we work to connect people struggling with hunger and diet-related disease to farm fresh, nutrient-dense food. And our approach certainly has evolved over the years that we've been in existence, but it's helped us to become a leader in food justice and more recently in food as medicine. We work to address root causes of food insecurity and food injustice, and we aim to serve as a model and a conduit to healthcare. We want to connect farms and food access programs, so farms, nonprofit farm organizations, food access programs. We want to be a connector between these programs across Massachusetts to healthy, nutritious food. So the next two slides, which we can go to now, these are going to show you some data points. And I brought these up early because maybe you all know this, but I like to include these data points just to make sure that we're really aware of the problem that we've got in front of us, that we're really working hard to solve. So we know food access is becoming a crisis. Food insecurity is on the rise across our nation, but right here in Massachusetts, that's what this slide's about. And the data on the slide is from a recent report that the Greater Boston Food Bank put out. It compared pre-pandemic food insecurity rates to food insecurity rates during the pandemic. So all of last year into this year. And we reached 30% food insecurity among our adult population right here in Massachusetts. And as you can see in the slide, the highest rates of food insecurity were among people of color and those with children. Some of the root causes were, there's many, the list is long, but land access, land theft, wealth inequity, low paying jobs, systemic racism. There's many root causes at the heart of what we see in the data points that I've outlined on the slide right here. Next slide. One before that. Yeah, there we go. Massachusetts, and this number, as alarming as it is pre-pandemic. I don't know what this number is today. I'm betting it's higher than what we see here on this slide. But nonetheless, Massachusetts spends pre-pandemic $2.4 billion annually on avoidable healthcare costs related to diet-related disease and illness linked to hunger and food insecurity. So diabetes, malnutrition, obesity, mental illness, cardiovascular disease. And the point of the slide is cheap, non-nutritious food is really costing us a great deal. We may not be paying for it at the cash register, but we certainly pay for it later on. We pay for it in healthcare, for example. And we can't ignore numbers like this, and neither can our healthcare system. So this is the work that Just Roots decided to dig in on. How can we engage healthcare stakeholders to invest in long-term solutions? Next slide. So Just Roots, I think over our decade or more of being in existence, we've become best known for our all-income CSA farm share program model. I won't assume that everyone on this at this meeting knows what CSA is, so I'll just briefly mention it. So CSA stands for Community Supported Agriculture, and it's a popular method for getting farm fresh food direct from the farm to the customer. The original model, deeply flawed when it comes to food access, because it's premised on a member's ability to put a chunk of money down, say $800 in the beginning of the season. That's great for the farm because it gives the capital the farmer needs to grow the food, but it's with the expectation that the member has the money to give earlier and come back later to share in the harvest. In New England, typically they're picking up their share of the harvest between June and October. Now, recent statistics say most Americans don't have $400 available to them at any one time in cash, so that we can deduce that means the majority of Americans can't access food programs like the CSA. So Just Roots set off over a decade ago to change that by reinventing the CSA model to address constituent identified barriers to food access. And this included lots of outreach, much of which Andy Grant, who's in the meeting, was part of. So things like holding focus groups with low-income residents. And through efforts like this, we learned a lot about, and we continue to learn a lot because this is an ongoing effort. It's not a once and done. So we continue to learn from those we serve, what's important to them to make programs like the CSA more accessible to them. So for example, an easy one is our CSA used to be seasonal. Well, we heard from people, one in particular, one member said, I'm not a bear, I don't hibernate, I still need access to healthy food off season. So we worked over the years to become a year-round CSA program, and we've done that. Just Roots is also known as the largest SNAP-enrolled CSA program in the Commonwealth of Massachusetts. And SNAP is Supplemental Nutrition Assistance Program, formerly known as food stamps. So we're the largest SNAP-enrolled CSA in Massachusetts. Next slide. So the CSA program that we run, that Just Roots runs, it features a subsidized share for income qualifying members. So if you're 130% or greater below the federal poverty level, you can receive a subsidized share. And then we offer a sliding scale, which you can see on the slide, a sliding scale along with flexible payment methods or models for moderate income members. This helps our moderate income members, people who might not be eligible to qualify for all the types of assistance, but still don't quite have enough wealth to be able to pay at the highest level. So we have this sliding scale with payment model, and then those with more wealth privilege pay at the top of the sliding scale. And the program that we run features standardly features culturally relevant foods, flexible pickup sites, so you can choose where you pick up week to week, bilingual recipes and resources, and compassionate customer care. And these things lead to really high retention rates, which matters when it comes to food as medicine. We see 90% retention rates, sometimes as high as 95. So we're seeing attrition, but it's within the 5 or 10% range. And what that tells us is that we're building health and the habits of cooking from scratch, those sorts of things through this program, and people are sticking with it. Next slide. So Just Roots has always been committed to tracking the data related to the impact of our CSA program. And we regularly see through the years results like that, like what I've included on this slide. So I'll just mention some highlights, and I would just ask that we go slowly through the next 2 slides because I included a lot of data points, and we've got 3 slides to capture all of that. So Hannah, you can move through them slowly as I speak, but I want to make sure people get to read them. So I'll just mention some of the highlights and then we'll move on. So some of the highlights of the impact of our CSA include improved produce consumption, improved physical, mental, and emotional health, more confidence cooking in the kitchen, decreased empty calorie consumption, and more. You'll see them. I listed a lot more on these slides here. So in addition to these things, we also see impact on food insecurity. So I think we'll go to the next slide. Next one, there we go. Okay. So on this slide, we see the impact that our CSA has on food insecurity rates. It's pretty dramatic. And you also see here the SNAP and HIP utilization rates. So I mentioned earlier, Just Roots CSA is the largest SNAP enrolled CSA in Mass. Why does that matter? We believe really firmly that it's critical to help people understand how to leverage the resources that they already have available to them. Resources like SNAP, and in Massachusetts, resources like HIP, the Healthy Incentive Program. We want to teach people that these are available to them and how to use them to help them participate in programs like the CSA. So HIP, just to say a little bit more about that, HIP, the Healthy Incentive Program, it's a program that's funded in the state budget and it further incentivizes the use of SNAP to purchase local fruits and vegetables from 4 types of local sources, including the CSA. Farmers markets, mobile markets, farm stands. So let's see. So basically, that's all to say that I think that including people in the local food economy provides a pathway for food and nutrition security, such that food and nutrition security can become a part of people's lives, all people's lives, regardless of your economic, where you are on the economic scale. It also provides a new constituent base for farms. So when farms are able to leverage SNAP and HIP benefits, or when customers are able to leverage SNAP and HIP benefits to participate in things like the CSA, all of a sudden farmers have a new market that they can pitch their CSA to. Typically, farms have to pitch their CSA to high-income members only. Well, that market is shrinking. So by including people in things like the CSA through model adaptation and the use of resources like HIP and SNAP, we're able to begin to have the CSA be utilized by more people, and that's good for people and farms. Let's see what else I want to say on this slide. Yeah, I think we can go to the next slide. All right, so data. I've mentioned data, I've shared some of it with you. All this data that we saw over the years really led to our decision as an organization to really dip our toe into research. So in collaboration with the Community Health Center of Franklin County and Dr. Seth Berkowitz out of UNC Chapel Hill, we ran a 2-year randomized controlled research study to scientifically test the impacts of the Just Roots CSA model. And this happened in 2017 and 18. Again, thanks to Andy for all your support on this. But you might be questioning, why research? Why did Just Roots dig into research? It links into how we were able to become a food as medicine program. We believed that research had the power to drive public policy and to interest stakeholder investment. We knew that basically as our demand grew for our program, we couldn't rely on fundraising alone to grow a big enough subsidy pool to meet the needs of all the people. We needed a more sustainable funding model, and we believed that the stakeholders that had an interest in this, the healthcare system, we saw that $2.4 billion, they needed to bring that cost down. We were interested in finding funding to support CSAs connecting to their patients. So together, we knew that we had something special. We've also always thought about the CSA that we ran as a model that could scale, and we had visions of scaling our model statewide. So in order to do that, we needed to have a pathway towards that financial sustainability for the program, for it to become a replicable model beyond vulnerable funding sources like a grant here or there, or private funding from a campaign of some sort. So let's see. So just to wrap up this slide, after the 2 years of data collection, what we were able to reveal and what came out in our published findings in 2 peer-reviewed medical journals was that indeed what we had been seeing in all the surveys over all the years was true. Our CSA worked to improve health, it worked to decrease food insecurity, and it saved society dollars. We weren't able to, in 2 years, move the needle entirely on reducing the cost of patient care, because often raw food interventions like the CSA take a longer period of time to do that, but we were on the right track. So good news all around. Next slide. Okay, so in 2020, Just Roots, as a result of the research you just heard about and our connection with FEMA, frankly, we were invited to partner with Boston Children's Hospital, accountable care organization, to pilot our CSA program with their food insecure patients through a direct referral program with clinics located in Hampshire and Hampden counties. So this is where we began to expand and formally become a food as medicine program with a direct referral. So we deliver our CSA program to the doorstep of these patients. There's 150 families that participate. This is a year-round program. It includes local produce, local protein. It includes kitchen equipment and cooking supplies. It includes those bilingual resources that I mentioned, and really, really compassionate customer care. So that's what our pilot program, the farm to family program, we call it, is being run. It started last June, and it'll run through 2022 with Boston Children's Hospital Accountable Care Organization as a partner. Next slide. And so this is, I think, my last slide. So in the fall of 2021, I mentioned we were going to be expanding into Plymouth County. So Just Roots is piloting the Boston Children's Hospital model, where we grow the food or aggregate the food and we deliver it directly to the doorstep of patients. I also mentioned we have interest in becoming a statewide model. Well, we can't do that by growing all the food ourselves. We can't just continue to grow more. So we need to partner with other farms. So we were excited to be invited by Partners Accountable Care Organization, which is Mass General Brigham, to launch another pilot program with them this fall. And that's in partnership with World Farmers, which is out of Lancaster. And World Farmers represent over 300 Indigenous, immigrant, and farmers of color that have access to land to grow food. And so basically through a contract, we contract for them to grow for 100 CSA shares to be connected with patients of Partners Accountable Care Organization in the Brockton, Mass area, which is in Plymouth County. So this is another way that we're connecting local food, local nutritious food from farms with patients within our healthcare system. So this helps their Farm Connect programming with healthcare without the heavy lift of things like HIPAA compliance. So to be able to connect directly with healthcare, there's a lot of requirements. Just Roots luckily is already invested in all of that. We have HIPAA compliant data systems, HIPAA trained staff, et cetera. We've already done that investment. Our farm partners don't need to do that. They get to do what they do best, grow and distribute food. We get to do what we do best. And this is just one of the new pilots that we're launching. We hope that over the next 2 to 5 years, these pilots will reveal data sufficient to secure long-term funding for food as medicine interventions like the CSA, because we've achieved the key data points: improved health, decreased food insecurity, and reduced cost of patient care. So that's what we are up to. And I'm gonna pass it back to Hannah.
All right, thanks, Jessica. So I know I saw there are a couple of questions in the chat, and I feel like those are some good questions. And I also want to save those for the discussion. But first, I think we want to dive into a little bit of an activity that will hopefully spur some more questions from all of you. So I will try to transfer to that. Okay, can everyone see the screen here? Okay.
Can I interrupt you again? I just want to switch our interpreters. So thank you, Julian, and I'm going to swap over to Nick. Just 1 second. Might take just a second for them to swap, but I think we should be good to go.
Have a wonderful day, everyone. Interpreter number one is leaving the building. Take care.
Thank
Bye,
you.
Julian.
Stay cool.
Bye. Yeah, you too. Take care.
Thanks. Okay, we should be good to keep going now.
Okay, so we're trying to make this a Venn diagram activity. So for those of you who might be unfamiliar with the Venn diagram, each circle is representing one topic. So this circle here represents the topic of food, and the other circle represents the topic of medicine. And then in where those circles intersect, that is where we're implying the world of food as medicine might lie. So all around this board, I have some sticky notes that describe words or phrases that could fit into either of these categories. And so I would love to hear from you all. I think you should feel free to unmute yourselves or maybe put it in the chat of where you think these sticky notes fit into either the food circle or the medicine circle or the intersection. And if you have suggestions for other words or phrases that should go into this diagram, you could also suggest those and we can add them. But to start, I think I can zoom in to this so you can read it a little bit better and to describe what we have. So I'll just read these out loud first. So using a blood pressure cuff, ordering pizza, school breakfast program, an EBT card, food banks, bringing food to a sick friend or neighbor, grocery shopping, soup kitchens, SNAP, medically tailored meals, mobile markets, physical therapy, doctor's visits, an annual physical exam, a prescription medicine, a canned food drive, insulin injections, meal kits, meeting with the nutritionist at a doctor's office, produce prescriptions, and a food pantry at a healthcare system, and then being told by a doctor to eat healthier. So those are just some examples to start with, and we will try to go from there. And you don't have to think too much about it. Just, whatever you think, you instinctively think that a phrase goes into one of the circles.
I guess one of the obvious is being told by a doctor to eat healthy. That would be medicine, or is it both? I mean, that's the whole thing. They both apply,
Mm-hmm.
but it's
Would
the
you?
prescription basically.
We can put that in the medicine
Definitely the
close,
shared.
close to this intersection.
Definitely.
Okay. And we can also copy these sticky notes. So if people want to add the same sticky note, but put it in a different place, we can also do that.
This is Roz.
Produce prescriptions.
Ordering pizza. I think that would probably go in the food circle.
Great. I'm sorry. And for the produce prescriptions, which category did you want to put that in?
In both. In
Okay.
where they both go together.
I see Tanya put in the chat, school breakfast program is food.
Okay.
Folks, feel free to add to the chat too if you don't want to unmute, or just unmute.
I guess usage of a blood pressure cuff would just go into medicine.
Maybe meeting with a nutritionist at a doctor's office could be put in both.
Okay.
In the chat, we have medically tailored. That could be both.
You guys paid attention to my presentation. That's great.
Of course, insulin injection.
Annual physical exam could be both to
Okay.
me.
Insulin injection. I mean, that depends on what you eat. I mean, if you're eating a well-balanced meal, hopefully you can cut down on your insulin. And if you stop eating the SADS diet, you'd be a lot healthier.
You can put that towards the center then.
Mercados móviles.
Mobile markets.
Mobile markets.
Maybe in both.
Okay. Where did that one?
Y abajo.
It's down in the pink.
There we go. Thank you.
The SADS diet is the standard American diet that we grew up with, which is letting us eat 4 servings of grains, which turns into sugar a day.
I guess I would put physical therapy and doctor's visits into medicine. Prescriptions too, perhaps.
And meal kits could be either, depending on what the meal kits were.
Mhm. Do you think they're either food or the center, or is that what you meant by either?
Yes, it depends on what they were.
See, we have food pantry at a health center or a healthcare facility would be both.
Okay.
Bringing food to a sick friend. I think most of you, you're going to have to make that middle circle bigger.
Yeah. Yeah, we'll have to overlap for now.
Okay, and canned food drive, I think, would be just plain food, probably, because we wouldn't.
Food banks would probably just be food as well.
Mhm.
And grocery shopping.
Those would really just be food access, basically being able to get food. SNAP, Soup Kitchen, and
Soup.
debit cards.
Okay. Does anyone have any additional things that they should be on this diagram?
Well, do we have mobile markets? I mean, we have grocery shopping, grocery stores. I mean, mobile markets have really been such an asset to many people in the rural communities and where no transportation has been available in the Amherst area.
Mm-hmm. So do
Thank
you want to add that to the food side?
No, that's it, you know. So much just fits together.
Yeah, great. So I'll just add it as mobile markets and make a note, especially in rural communities.
And we don't have like farm shares or CSA programs, do we? That
We
could
can
be,
add
I guess,
here.
food, yeah.
We didn't want to be the one to say it.
Wait, the farm share. And then I see Ruth mentioned raised bed garden or even just gardens. Community gardens or home gardens.
Mhm. And would those go on the food side?
I'd say it's
Yeah.
it moves closer to food as
Talleres.
medicine, I think. Oh,
Great.
Johanna has something to share.
Oh, sí, que, o sea,
Oh, yeah.
talleres para
Um,
para,
and
una
for
zona de que aprendan a cocinar los
for healthy food and people learning how to cook vegetables, because there are people who may like vegetables but not know how to even cook them and not even be aware of how good they can be in a meal. And so educating on how to use vegetables, like teaching people not only about the vegetables and their nutrition, but how to cook them, like maybe workshops, healthy cooking workshops.
I apologize. Is the translation able to go back to English?
And those recipes, I mean, that would also, you know, Johanna's idea would also go with those recipes that you sometimes share with CISA or whatever. I know in the Boston area, they have that food delivery system. I forget what it's called. But in some of the more urban areas, you can have good, healthy food delivered to your home. We really don't have that out here in the hills, but
Yeah, local food delivery services,
that
especially
can be costly, right?
up during COVID, I think, right?
Mm.
I want to make sure I captured what Johanny said. I don't speak Spanish. So are we able to get a translation of that?
Oh, yes. It might be because you're not on the English channel that you didn't get
Oh,
the
okay. Sorry.
interpretation. So if you go on the bottom and select English, you should be able to hear it. But she was, I think, talking about like healthy cooking classes and workshops, teaching people how to use healthy vegetables to make tasty and nutritious meals.
Great.
Because I know sometimes people get collard greens in our area. What are these? What do you do with these? That's a great idea. You know, they need to know how to use and eat the collard greens.
Yes, definitely. I'll put that in the middle. Is that what you all think where it should go?
I think so.
Okay, great. Anything else maybe in the next couple minutes?
Yo pondría a los mercados móviles.
I would put mobile markets right in the middle, because mobile markets always have the fresh, organic produce from local farms that are always vegetables. So it's healthy, and yeah, I would put that in the middle, because what we have for the most is that to get people to consume these fresh vegetables at the markets. And so it's food, but I think it's also medicine.
Great. I moved both of the mobile markets more towards the center.
And I see Lauren, you have your hand up. Go ahead if you want to unmute.
Yes. Hi. I actually saw only soup instead of soup kitchens, and I was gonna put it over at the medicine side. It says kitchens, but I don't see anything. When we say food is medicine, I don't see any of the food over at the medicine side.
Yeah, I think that's
but I'm mistaken. Yeah.
Lauren,
soup by itself.
I think that's a good point, is that, you know, we can go into this in discussion, and maybe that's actually the perfect transition to go into a discussion, is that, you know, all of these things that we've identified as being on the food side, all food has an impact on our health. So at what point do we want to think about how each of these, you know, purely maybe food items can also start to transition into the medicine side of things. Yeah, thank you. Well, first of all, thank you all for participating in this activity with the tiny little sticky notes. I apologize if they were hard to read. But yeah, this is a really great brainstorm with you all, so thank you. So yeah, so now we're hoping to, I think based on the size of this group, we can just do a discussion in one group versus breakouts. But we wanted to hear from you all a little bit more about, starting with this activity, but hear from you all a little bit more about what food as medicine means to you. So first of all, just want to hear from you all. Have you heard something be called a food as medicine service before?
Some.
Okay, we have some nods, some no's.
Yeah, we could use the chat or the reaction. You can use your hand raise or a thumbs up, maybe is easier for some of these, if that's useful.
Yeah, Andy?
I'm familiar with the program in Virginia, and this was about 5 years ago, called Pharmacy, spelled with an F, where people receive prescriptions for food from farms.
Great. And so those of you who have heard of food as medicine as a term before, what was your impression of that?
I'll mention, I think the Hilltown Health Center, I think, has run in the past what they call, I think, a produce prescription program. And I don't know if Roz or Robbie might know more about that, or Kat. But I think it's a, you know, a coupon-based program, like you talked about, that folks can bring to the mobile market to cash in for vegetables. But I honestly don't know. I would love to learn more about how that program has run in the past. And my impression is that people really like it, and that community health workers are also play a key role in connecting people coming into the health center with, you know, where the mobile market sites are. So I guess that might be a really important thing to think about. Where are people making the connection between health center and the site where they can get where they can cash in their coupons and get fresh produce?
I know the CDC did a great job with the food box, which ended up really helping people get meat and protein. And that's just been wonderful because people say, my goodness, we're getting vegetables, but I need meat and I can't afford it. Of course, the price is so horrible, and that's going to be ending in August, but it has made a positive impact on so many families. I don't believe the coupon system, my understanding was that it was underutilized, but prior to COVID, it was underutilized. I think people are utilizing those things a little bit more. And locally, I know someone mentioned in the chat about HIP and why HIP is underutilized. And I think HIP is being underutilized because people are undereducated and they don't understand how that it's okay if they have, well, yeah, their SNAP benefits for seniors is what, $30 a month? That's not going to give me anything. But if they realize that on top of that $30, they have the $40 of HIP vegetables, everybody, senior, older, whatever, and and they just, even though the debit card says only 10, you still have that invisible $40 to spend, and just education for that part is in food access and education, which is education of how to use different foods. I mean, people walk into a grocery store and they say, what food is that? Because it's an ethnic food. What could be better than to have recipes and to have people being able to try new foods and their benefits.
I really appreciate making that direct connection. I mean, for years now, I've worked on various projects around Go Fresh Mobile Market in Springfield and cooking classes at the Caring Health Center and prescriptions, but it's never had this like language. I think that the more that can be introduced as food as medicine, and it's one of the things that I'm really interested in now in my role at the university in the dining program, is making that connection to young people earlier. And being able to develop that language to be thinking about the nutrient dense opportunities as they decide what they're going to put into their bodies. So I think that this is wonderful.
Yeah, I think it's really important, building on what Kat and Kathy have both said. The education and language and communication piece are just really important, especially where we are, Kat and I are in the hill towns. We have a real difficult time with being able to communicate and educate, and we have problems with transportation as well. So this is really important in getting this piece with food as medicine. It's just really important for our area. Yep.
I know Meals on Wheels programs is a great idea, but for instance, I mean, 20 years ago, my mother was part of the Women's Health Initiative. And it actually, because they were doing the SADS diet, it brought on her celiac disease because they were making her eat 4 servings of grains a day, and she became ill. And that's just one example. I know people who try to do the Meals on Wheels had become ill because they're on a low salt diet or they have food allergies and they were not able locally. I know Hannah mentioned that maybe up in the Boston area, they have a better system for medical needs of food, but locally, they're not able to accommodate people with food allergies or food problems or sensitivities. So we still have that problem locally, although we do have access to Meals on Wheels.
Yeah, I think that's true too, like Kathy was starting to say about younger kids in college, but also even, high school and elementary school students and school meal programs. I see Roz has had her hand up. Go ahead, Roz.
I was just going to say, I mean, I know for myself and friends and a number of people, the idea of food as medicine has been part of our thinking of our health in general. So it feels like there are a lot of people out there individually who have been working with this and making this connection. But it's only recently that I've become aware of the organized efforts to truly deal with food as medicine, which I think is terrific, because it's about connecting all the different dots and really creating a whole almost movement, which I think is happening, and I think it's terrific.
Jessica mentioned that I was involved in the research, the food is medicine research that Just Roots undertook. And what I remember from meeting with people and hearing their stories was how energized they felt and basically happy to have access to farm fresh food. It just, apart from like the statistics and the medical model, the human experience was joy and greater like energy.
Yeah, and I wanted to just say something about I've mentioned and others have mentioned nutrient dense food. And so we can't really talk about food as medicine without talking about soil health and regenerative agriculture. It's directly linked. So soil and our gut. And so it feels really important to continue to remember, even if it's a fruit or a vegetable, there's still different qualities, how far it's shipped, when it was harvested, how long it's been, stored. These sorts of things diminish the nutrient value. And so that's why I didn't say it out loud, but the connection between people and planet, this all links back to food as medicine. So it felt really important. We're lucky here in Western Massachusetts, where we have, at least in the rural parts, the ability to grow a lot of nutrient dense food through regenerative agriculture, but that's not the case everywhere. And some of the key outlets where people have the most access to food, they don't have as much of an option to choose food that is grown in that way.
And the whole misconception when it says organic does not necessarily mean it's really organic. I mean, that's not a controlled word. And you're paying twice as much for something that probably has just as much pesticides and was born in dead soil, and you can taste the difference. But that's why the whole blessing it is with the CISA program and the CSA program, is because we're going from farm to table. We know the farm, and we're lucky, like you say, rurally, because we do have many great farms we can access for beef as well as for vegetable.
I know there are two more hands raised, and then we'll move on to the next question in our discussion. But we'll start with Rosanna.
Sí, quería añadir.
Yeah, I wanted to add just that it's fantastic that this program exists and available in the area, that it's helping that point of process. And what we need is to be more connected to all the programs that we have to be able to complement them. This is really important. We need to be accessing all the programs that exist and connecting people through those programs and through those efforts that we're doing together. And the other thing is, food is medicine, yes, and that is fantastic. I would also add that besides medicine and food, we could add flavor, because flavor is really important. And our kids, they'll tell us at every moment, every time they test them, every time they check for what they like at school, and they'll say, I don't like school food. And I know you have been part of those things based on what the food that has been available, because there hasn't been good food, but also flavorful food in all areas, including our schools. So what should we do? What are the recommendations? Because I don't know, we at home, we can make flavorful food. this is why I feel like this is something that should also be done in schools too, so that schools can also, children at school can also be enjoying this food. Thank you.
I do.
Rosalind?
Part of
Yeah,
the thing.
I would just also thinking about the emotional and psychological component of food, which is also related to health and medicine. And for me, certainly growing up Jewish, food is about joy as well. And there's a lot of emotion tied up with eating, and emotion is tied up in mental health as part of our physical health. And so it's really also connected. So the importance of, and also the spiritual aspect of food and how it brings us together and the connectedness. And again, I don't know how you separate any of that from your physical health. So it's all very, very connected for me. So yeah. And I'm in the process of eating ice cream, and there's nothing more glorious than that. It may not be the healthiest thing, but there are just times when food is pure joy. So it feels healthy on that level. Done.
You know, I
I
think
hope you enjoy that for all of us, Ross.
I think the whole point of food being flavorful and tasty is important. And then you have the whole ethnicity behind food. I mean, the best food that tastes is what you come from your mama's table. And if school food probably tastes very foreign and unpleasant, and the textures and the visuals would be very unpleasant. But I do know our school systems are tied to the standard American diet. They're tied to being able to serve certain things. They're tied to whatever they get or are told to serve. So there's a lot of loose ends there that could make a better world through education and through legal documentation to say, hello, this research shows that kids are not doing well on this lunch program that's making them eat how many grains for breakfast and lunch, and then they go into a coma in the afternoon and they can't function because they're falling asleep because of all the pasta and the bread they had to eat for breakfast and lunch. Anyways, I resent it. Sorry, but food is important.
Yeah, so I also want the group to reflect a little bit about the definitions that I introduced earlier in my presentation, and the activity that we did just now. So how did, how did you decide what words or phrases belonged in each circle? And also, how would your definitions, as we did in the activity, fit into some of the definitions that FIMA has described? So I'll pull up the pyramid again briefly so you can be reminded of that. But I'm just wondering about how the discussion we just had and the activity that we did, how all of that might affect your understanding of this set of definitions and set of interventions that are very specific.
I'm just gonna speak up if that's okay. I mean, I think in my mind, I like to think about eventually there's not two circles in the middle. It's like, would a win be if all the food stuff was actually, it's all just one circle eventually? Because really you could think about all of those food components getting in the middle or even in the right-hand section, depending on how our medical professionals become educated about and begin to talk about and have access to the knowledge that they need, the connectivity they need to food as medicine interventions that are up and down this pyramid. Without their curricular education, ongoing education, and a community awareness of where they can refer people into programs that fall within this pyramid, we will always have a disconnect. So, so a lot, like just similar to Just Roots, like we had a CSA, it wasn't directly connected with, it was the lower level of this pyramid until we started making relationships with our health providers and establishing concrete ways of having them understand what we had to offer and to start to refer people into our program. And then the next level was they started actually paying for the program to be connected with their patients. And so that's a nice trajectory for what was a basic population level healthy food program, which is now up into the nutritious food referral level.
Jessica, if I could ask, there was a comment in the chat about reluctance in participating in a broken system, that the medical system as constructed is biased against BIPOC people in particular. I wonder if you have a comment about that.
Yeah, I have more than a comment about it, Andy, but I mean, I think we can't change a system unless we work on it. So I agree that it's deeply flawed. We've got a long way to go, and we're working on it. And so one of the things we need to make sure we do, and FIMA is actually doing similar work as this Food Policy Council is, in terms of becoming more inclusive of the the general public, so to speak. So not just the people, the decision makers, the people in power sitting on a coalition, but all people sitting on a coalition. So that way we're inviting all voices and listening to all voices and informing the solutions from a place of inclusivity, diversity, equity, and inclusion. And so I think we have to engage people in sharing their stories. Stories are really powerful. And I agree with what everyone has said about like the diet. Like there's so many BMI, our standard American diet, the USDA standards, these all need to be not just looked at, like they need to be redrawn and re-specified according to a more culturally and racially diverse population, which we are. And so we need to continue to work on investigating and looking at and dismantling the systems of oppression that are woven throughout our medical system. But that doesn't mean we can't be doing this work along the way. We've got, parallel paths.
Mm-hmm. Yeah.
Thank you.
Thank you for raising that question, because I thought that was a great question that was posed in the chat. And I'm sorry that Elisa had to leave before we talked about it. But I think that's something that we've been trying to think a lot about as a coalition, because a lot of the work we have been doing is in fact within the current system. And so that is indeed what we're hoping to do is, how can we also advocate to change the injustices of the system as well?
One of the things I think it's heartening to see, and I'm very glad you pointed that out, Jessica, that you have moved up the pyramid as far as your influence on professionals, because basically most professionals were not changed in wellness care. They're trained in sickness care. They're trained to pass out a Band-Aid. They're trained to cover it up with medicine instead of getting to the heart of the problem, which is usually nutrition. And so it's basically a wake-up call. I know part of the Native American philosophy is the chief is responsible to the 7th generation. And what you hear in our culture far too often, it's not my problem. And that hurts. It hurts us all, because it is our problem, and it's the problem for the future. So what you guys have been accomplishing has been great.
All right, so I'll ask, oh, sorry, we're about to say something, Jessica.
Well, I don't know if this whole group is aware that Massachusetts is really investing in the exploration of programs to address food insecurity through a program called Flexible Services, and it's funded by Mass Health. It's through 2022. The money and the program description is within the 1115 waiver, the program requirements, and that's due to be renewed. And there's been a lot of efforts to try to ensure that flexible services is renewed through 2025. And what that means is that accountable care organizations across the state, there are 18, can have funding available to work with community partners to address food insecurity and housing insecurity. And we're doing this in such a way that it is a direct referral program. So it's within that middle level of the pyramid all the way to the upper level. It's above prevention. And well, it's prevention treatment, I guess. And we're collecting data, as I mentioned in my slides, so that we can prove an investment is worthy of being continued. And so I feel really hopeful that through this statewide initiative, that we will have enough evidence in 2 to 5 years time that we will continue to see a continued robust investment from Mass Health and other funding potentially to continue with these sorts of direct connective points between local nutritious food and food insecure populations.
I have a quick question. Do you know what the percentage of white Americans fall under the poverty line in terms of food insecurity?
And I didn't hear the last part of your question.
Simply that, do you know what percentage of white Americans are under the food insecurity? So they're poor people. You know what the percentage of white people are? Would you know what that is?
On a national level? Or here in Massachusetts?
It doesn't matter. Massachusetts or the country, doesn't matter.
I think it was, I had that in one of my slides off the top of my head. I think it's like,
I thought I saw 40%.
Well, 30%, but that's all people. And you know, it was like 26%, I think, Latinx, 24%. I'm doing this from memory. There it is. Yeah, it's 58% Latinx, 54 other, 45 Black, 26 Asian, 24 white. So we are, you know, obviously it's the lowest. Well, not obvious. I guess for me, it feels obvious that white people are suffering the least here. So, and we see that, you'll see that mirrored in national statistics as well, and local statistics, in fact, as well, if we drill down to the county levels.
I'm not sure how accurate that is when you're referring to seniors. And a lot of the population, of course, in the Hilltown is predominantly white, but there is a lot of food insecurity among seniors because their income doesn't change. But the cost of going to the grocery store continues to change. What they used to be able to get for $30, maybe 2 or 3 bags of groceries, they're lucky if they walk out with 1 bag of groceries.
Right,
So,
and I think that's a really important point, Kathleen. And I hope someday, I was on vacation with my family and I heard over and over the course of the week, people saying, I got this deal on peppers or this deal on I got like $1 a pound for beef. And I just thought, oh, geez, you know, who suffered for that low cost of food? Not just the healthcare system, the animals, the farmers who raised or grew that food. I mean, it's just, what will it take to get to the point where we are willing and able being really important, willing and able to afford to pay a lot more. We spend so much more on healthcare than we do on food. And that's got to flip. Those numbers have to flip. And it's wage and, you know, it's cliff effect, it's wage inequality. It's a lot of things. But eventually, to solve this problem, we have to start paying a lot more for food than we do today.
Can I just, I don't know if I agree with that, but I just wanted to add 2 things when we talk about food as medicine. One being oral health, which is no one, I don't think, ever speaks about that when they talk about farm to, mobile markets and how we're, consuming our food. But that's how we eat. We eat with our mouths and our teeth. And when you start like getting older, not necessarily, but that might be a factor, but even like just how minorities and people of color are dealt with in the healthcare system, we receive more traumatizing, services. Well, the services that we receive are more traumatizing, I can say it like that. And especially with oral health, that has to be a factor when we talk about, overall health and how we consume food, because that's how we're, digesting our food. And also, I just wanted to add, I am shout out to everybody from the governance circle. I am a community participant with the Amherst Mobile Market, and I also just wanted to add that because our healthcare system is so traumatizing in how we might interact with it. We do need to have medicinal ways to heal ourselves through whether we're growing our own food or those recipes that are given through the community and through families or our grandmothers, or however we find those healing recipes. I think we have to recognize that the healthcare system is traumatizing in a lot of ways.
Can I finish my last part of that question I was asking, please? So my concern is that, for instance, when in terms of the work that you do, which I think is really important and should be done in a way that give the society at large a much more clear idea. And so, as an example, when you roll out and you would say something like people of color or Latinx or whatever terminology used, I hope what starts to get into the lexicon of American talk would be to also roll out all those only 25%. But I certainly would appreciate it if, in that vein of thinking, that one would say 24% of poor white Americans are in fact suffering from food insecurity, suffering from going to the hospital, succumb to not being able to pay rent or have heat in their houses. Because I think one of the biggest mistakes we make in the society is that somehow or another there's this friction that goes on between people, so-called people of color, and white Americans, is that they're never shown that there's white Americans in this country that are suffering every single day. They don't have food. Some of them don't have clothing. Some of their kids don't have shoes to wear. So I would appreciate it if you can, when you roll out who suffers from food insecurity, that it becomes all those things you read off, like in the Latinx and the Black people, I mean, people of color, and also the poor. I like the word poor white people, because they are suffering like everyone else is.
Yeah, thank you for that.
Yeah. So I'm hesitant to go back into some slides because this conversation has been really great. But I do want to introduce a little bit about what FEMA does, because I think a lot of the conversation we've been having is a lot about what can we do to improve this system. So for that reason only, I'll go back to some slides in the hopes that some of this will be helpful for all of you to have a sense of what can be done to improve the system. So try to go through these quickly just so we can have also just a little bit more time to ask any questions. Okay, So FEMA as a coalition works on a few things. One is we have an inventory of taking note of what programs are happening across the state. And we also work on advocacy. So as Jessica mentioned, the Mass Health 1115 waiver is really, really important for Medicaid, which is, healthcare for low-income Americans. This is a new project or a new program, relatively new in Massachusetts, where Medicaid is actually paying for nutrition and housing services. So that's a large piece of the advocacy that we work on. We also advocate for what's called the Food and Health Pilot Bill. This is something that is sort of, FEMA likes to call it our bill. And this also, this pilot would also create a nutrition program through Mass Health across the state. But I can go into more of that later or share some resources for how you can learn more about it. We also work through some task forces. So we have 3 task forces. There's the CBO, or Community-Based Organization Task Force, and which Jessica and I, in addition to the Boston Public Health Commission, co-lead. And the mission of that task force is to expand equitable access to community-based food as medicine services. The research task force works to support and disseminate research. And then the provider nutrition education and referrals task force, that's also a mouthful, works on supporting nutrition education for healthcare providers. I'm really glad that someone mentioned oral health, because that's also a large part of what we're including in healthcare providers, is both medical providers and oral health providers. So some of the various publications that we've created over the years, this is also just sort of what FEMA does as we try to get the information out. So we've created some definitions and standards, as I shared with you today, about what food as medicine interventions are. I mentioned some of the policy work that we do, and generally we support policies that integrate the food and healthcare system. And then some of, again, just for getting the information out, some of the publications that we've put out are on oral health and nutrition, food as medicine for high-risk pregnancies. We have the most detailed list of mapping resources on food as medicine for adults with disabilities. And as I mentioned, also, we are working on a statewide inventory of food as medicine programs. So for those of you who are interested in the advocacy side, FEMA has 3 tiers of what our priority advocacy areas are. So the first tier are policies that directly support food as medicine interventions, or have support for direct integration of food as medicine interventions into healthcare. The second tier of policies that we support are those that advance healthcare's ability to address the more generalized nutrition needs of individuals, as opposed to the more specific needs that might be for someone who is experiencing who needs a higher level of a food as medicine service. So for this type of work, we might recognize that there are other coalitions who are taking the lead on these sorts of advocacy activities. So we just assist as a coalition in supporting those other that other work that's being done. And then the third tier are policies that improve healthy food access, reduce food insecurity, expand access to social services, and strengthen local food systems. And again, in this case, we want to support the work that other coalitions or organizations are doing. So we share the information that they're doing with our members. We already talked a little bit about the 1115 waiver, but this has been a really exciting opportunity for us to advocate for sustainable funding for food as medicine services throughout the state. As I mentioned, we advocate to protect and expand the funding for this program. And we created a comment letter that we sent to Mass Health that details what specifically we see as the areas for improvement and what we do support about this program. So that letter is linked if you want to learn more about it. The food and health pilot bill, as I said, this would also create a statewide nutrition program with Mass Health. One of the key parts about this pilot is that, you know, right now there might be a healthcare system that has one connection to one specific type of food as medicine program, and that's great. But we know that there's such a wide range of food as medicine programs that there are different eligibility requirements, and not all food as medicine programs are appropriate for all people. So we want to be able to test a system that can effectively triage Mass Health members into the most appropriate food as medicine service for them, and then see what the effects are. So the link in this slide is for a one-pager on this bill. I mentioned the inventory. So some of the reasons why we do this work is to increase the healthcare provider awareness of the programs across the state, and also provide a network for food as medicine providers across the state to really to dive deeper into the food as medicine world and be able to expand their networks and be able to connect a little bit better and to the healthcare space. I mentioned the nutrition education. We've talked about how important that is for our healthcare providers to know about nutrition. As it stands, nutrition education is pretty dismal in medical and dental schools. So we are advocating for that to be improved. Also, as Jessica has said, research is so important. So we have worked to support the research on food as medicine, because a lot of policy change comes from research. A lot of convincing the people in the room why this is important comes from the data. So yeah, so we work to support that research, support the network of researchers, support the quality of the research. That might mean more community-based participatory research, that sort of thing. And as we talked about before, we also want to expand the diversity, equity, inclusion of our coalition and have increased community engagement. So all of that is going to be really important, especially as we start to understand how the systems are broken when it comes to racial and other injustices. And that's why it's really important for us to have active participation from more than just the professionals in the room. And then we also work as the CBO task force to provide some technical assistance. So that basically means education. So how can a food as medicine provider better understand the world of local food provision, for example, or how to become HIPAA compliant as they start to move into the healthcare space. And lastly, just some ways to get involved with FIMA if you're interested. So if you want to learn more about what is happening with food as medicine in your community, you're interested in advocacy, you think you might have a perspective on how to improve food as medicine services themselves, then, you know, we always encourage people to join FIMA. You can join it just as a general member, or you can also join as a task force member. You can also just participate in our advocacy activities. And we also know that a really good way to learn more about food as medicine services is to volunteer at one of them for those of you who have the time or want to make the time to do that. So here's just some information on a little bit more detail about all those different ways to get involved. But the main thing I'll direct you to is our website. So foodismedicinema.org. And that's where we have all of the resources that I linked to throughout the presentation. But that's also where you can sign up to join. So thank you so much for participating in this discussions with us. We are really glad to be here. I hope you've learned some things about food as medicine as well. And I think that leaves us with about 5 minutes. So yeah, let's see, I don't see.
Yeah, thank you, Hannah and Jessica. That was awesome. So super informative. And I really appreciate all the examples and, stories about what these programs look like in real life, because I think that can be sort of the vague part sometimes, understanding what does this really look like in communities. So it's so awesome that we have such a great example right in Greenfield to learn from. So yeah, I think we've got just a couple of minutes if there are any final questions. I see Lauren had a question here. When you say food as medicine providers, do their programs get funding or a certificate? Like, is there some way that we know that this is a food as medicine provider?
Mm-hmm. So for the way we define it is what qualifies a program as a food as medicine provider is if they meet the definition. And so, for example, with this inventory that we have, if a program meets one of the definitions, then they'll be included in the inventory. But we're not doing like an accreditation program, or we're also not doling out funding. We're just also a coalition that has, no fiscal agency of ourselves. But hopefully together we can all, the goal of the coalition is to make sure that each of these programs does have as much sustainable funding as possible.
Awesome. Thank you for your email, Jessica. If folks have questions or want to learn more, it sounds like Jessica's willing for you to reach out, and I'm sure Hannah is also.
I'm putting my email in the chat.
Great, perfect. And we'll also be able to post this this actual recording on our YouTube channel. So if you know someone that didn't get to attend today and you feel like they really, benefit from listening to this presentation, we should be able to get it up within a few days. So we usually send out an email afterwards we'll send the link to the recording and, save the date for our next July Learning Circle. All right, it's been a really awesome 2 hours. I'm so glad we've got this last group of people that stuck it out for the past 2 hours. I know it's a long training and it's really hot, so I'm sure everybody has to go meet their own needs right now. But thanks again so much for presenting. And I'm really excited to see, where the Food Policy Council can sort of intersect with this work, because I think there's a lot of folks who are interested in thinking about what this might look like, what FIMA might look like, or food as medicine in general in Hampshire County. So I'm sure there will be more to come and more conversations that we can have going forward.
Yeah, thank you all for the conversation and your questions. They're really, really great.
All right. Goodbye, everybody.
Everybody.
See you later. Stay cool. Take care.
Thank you.